for joining us for this month's second Teach Educational Rounds. Back in August, if you recall, Dr. Selby presented part one of this series where he discussed integrating a mood intervention into smoking cessation programming. And today we're going to continue that discussion with part two of this series where he's going to be introducing the STOP program's mood management initiative. So very briefly, I'm just going to go over some housekeeping slides and then we'll begin. So if you are interested in obtaining a letter of completion for this Teach Educational Rounds, please make sure that you have registered for the webinar and completed the pre-learning assessment. You are currently signed in to view the webinar using your first and last name. And finally, after the webinar, I'll be sending out a link to a post-learning assessment and evaluation, which you'll have 1 week to complete. Now remember that these webinars are being live tweeted on Twitter, so you can follow the KMH Nicotine Dependence Service at PS Quit Smoking. And if you'd like to post your own questions or comments, you can use the hashtag #TeachWebinar. Here is our faculty bio for Dr. Selby. Dr. Selby is the Chief of Primary Care, Director of Medical Education, and Clinician Scientist at the Center for Addiction and Mental Health, and he is also the Executive Director and creator of the TEACH Project. Here are Dr. Selby's disclosures, as well as our disclosures. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario Ministry of Health and Long-Term Care, and contents of the slides were primarily based on evidence from the following sources. And remember that these materials, as well as the verbal presentation and any discussions, set out only general principles and do not replace the need for individualized clinical assessment and treatment plans by a healthcare professional. So before we begin, I'm just going to go over some polling questions just to gauge who's joined us here today. So using your computer, and you may need to scroll down again, just indicate which of the following disciplines you are working for. And it looks like we have a lot of registered nurses here today. And again, using your computer, please indicate which of the following you work for. If yours is not listed here, you can always type into the chat box. But it looks like most of us are from family health teams and community health centers. Awesome. Okay, and finally, please indicate which region your organization serves. So I do see that we have a lot of people out of province, so do you want to indicate where you, okay, Government of Nunavut, that's awesome. And then the GTA as well. Okay. All right, so with that, I'll let Dr. Selby take over. Thank you.
Thank you, Shalisa, and welcome everybody. Before I get going, we want to acknowledge the passing of Gord Downey in Canada today, and the great contributions that the HIP have made to all of us, and I think everybody has a story. So having said that, I appreciate that we have at least 106 participants on this webinar today, and that there may be more because sometimes people sign in and there are more people at first sight. So without much further ado, I want to get going. So as you know, people's mood can change, and it can range from being a momentary state, whereas and not a disorder, but that's our natural reactions to sad events. But over time, some people can also develop a condition called depression, as even though that's a common language term, they can develop depression. And in most frontline settings, we see people with a range of issues where their mood is low or sad, and it can be because something sad has happened in society, in their lives, momentarily, or it could be grief, or it could be sadness because of a loss. of some kind, or it could be actually a clinical depression or worse, something that is part of a bipolar disorder, for example. So, and interestingly, depressed mood, as you know, could also be part of a medical illness, and not even because the person is actually even knows that they have the diagnosis, but it's a mood state, negative mood state, because they're ill. Anyway, so what we're going to do is these three things, is looking at tailoring some interventions that are possible within primary care and community settings and non-specialty settings to address major depression, which is, as you know, is a barrier to our cessation success, which we talked about in the previous webinar. And if you haven't seen that, it's recorded and archived, so please feel free to review that. We want to talk about seamlessly integrating mood management brief intervention into smoking cessation treatment, because we recognize that we often will recognize and detect that people are sad, but we don't necessarily have the guidance or the pathways to manage that mood state. And then lastly, is we have the STOP portal, and some of you are participating STOP sites, and others are not. And so there's a question at the end: if you're not a STOP site, we are thinking about ways in which we could actually make our portal more available to others who are trying to do smoking cessation in a more comprehensive way, taking it beyond the 5 A's, taking it to actually understanding the person who not only is smoking, but is also has other conditions going on, such as depressed mood or drinking too much. So, without further ado, let's take a look at what are mood disorders. When we talk about mood disorders, these are serious medical conditions. So notice that I'm using the word medical. These are not just life issues that are part of the human condition. But these are serious medical conditions that will affect how people think, behave, and function. And people might experience highs and lows with greater intensity for longer periods of time than most people. So when there are the highs and lows together, we call that bipolar disorders, and sometimes an episode like that would be called a manic episode. And then lows can be part of what sometimes is known as a unipolar depression or a depressive disorder, or bipolar disorder, and sometimes some people even make, it co-occurs a lot more commonly with anxiety disorders, where people are anxious, worried, etc. So they range in severity, as we talked about, and they go from no symptoms, minimal symptoms, to major depression in that range of actually having the clinical depression, but it's mild, moderate, or severe. So just remember that that's the spectrum. These are all spectrum disorders. These are not clear-cut, and there's a lot that can be overlap between each of the categories. So when you look at somebody having a major depressive disorder, they should have had at least one or more major depressive episodes in their lifetime to qualify. So one of the tools that has been well validated in primary care settings and seems to be has had good uptake and actually works quite well, and especially that's our observation in the STOP study, is that the PHQ-9, it's a 9-item tool that helps screen, diagnose, monitor, and measure depression severity. And it's a pretty simple response option, a 0, 1, 2, or 3. And item 9, in that, the last question is about suicidal ideation, and it is currently used in the STOP program. So it's an excellent screening tool that we have integrated, and it seems to have had good uptake. In the last one, we focused on the minimal depressive symptoms, 5 to 9, and just oriented you to the PHQ-9. Today we're going to talk about the scores, 10 to 14, 15 to 19, and more than 20. So this is the major depression with mild, moderate, or severe, and that's going to be the focus of today. So major depressive disorder in Canada, it as you know, impacts overall health, the way people live, the quality of life, adherence and cooperation in medical treatments, other medical treatments, and is a major risk factor for obesity, for smoking, and whether the people are going to be physically active, as well as it's a major risk factor for cardiac disease, and can occur after people have had a major cardiac event. 11% of Canadians experience major depressive disorder in their lifetime. So 1 in 10, that's pretty high up there. And 1 times the increased frequency of primary care visits. So people with depressive disorders are seen more commonly in primary care visits, and we're beginning to see that people with mood disorders actually may be accessing primary care settings, but they may not be getting their full care because there are too many diagnoses going on for each visit. Now, one of the things that we have to pay attention to is with major depressive disorders and suicide, because suicide is one of the most common preventable causes of death in young people, and sometimes in the elderly as well. And a lot of it is two major causes. One is depression, and the other is substance use. So it's 4,000 plus suicides in Canada in 2013, and 60% have been linked to mood disorders. So, and many people who land up completing suicides have had some touch with the healthcare system, and mostly they will have seen primary care systems, not the specialty psychiatric systems. So as the medical home and primary care is becoming much more articulated, people are coming in. They're not coming in because they're suicidal. They happen to have other things and they come in. So in part, we need to think about this. And risk factors for suicide is still being studied. It's one of fairly understudied condition, but generally we know what are some of the risk factors. We don't know what are protective necessarily, but we know what is our risk. And we know that being a male puts you at higher risk, being single, divorced, or widowed, having a lot of stress, anger, and substance use, as well as having lost jobs or sudden major changes, can put people at risk. Now, there is an association, actually, that went between tobacco use and tobacco addiction and suicide risk. So there's more smoking, more risk of suicide. But it's not clear whether there's something specific about smoke itself that makes people's brains and affects the brain functioning so that people become more suicidal, or is smoking going along with other conditions that then make the person much more vulnerable to suicide? And that's not yet clear. So when people have used substances, there are factors within that whole process that increase the risk of suicidal thoughts or attempts. So clearly just having a tobacco use disorder, or previously called nicotine dependence, puts you at risk. But it's not just that. It is possible that during withdrawal, people do experience negative mood states, and that might themselves make them, during that quit attempt, suicidal. Clearly, we know that people who use tobacco also use other substances, so if they are often sometimes changing tobacco use, they're also changing other substance use, and vice versa. So that, again, may be one of the reasons why they get more substance use. And we know that as people are quitting smoking, depressed mood is part of being in withdrawal because there's the harmine and non-harmine, which are chemicals in tobacco smoke, not the nicotine, tobacco smoke, that is affecting the way brain chemicals like monoamine oxidase is being broken down, and that changes as well. So it's highly possible that there's something going on there that makes people much more depressed and suicidal. And then clearly we know that intoxication, not necessarily intoxication with nicotine, but intoxication from other substances increases the risk of a completed suicide. So clearly these are some of the factors that we see with smokers. It's confounding by these other factors and the state in which somebody is when they're quitting smoking. So we know that depressive symptoms, as I said, worsen when people try to quit, and this is one of the factors that is associated with relapse, actually. And we know 60% of individuals with a history of depression are current or past smokers. So we can't ignore this anymore, and we talked about in the first webinar that it is an important factor to keep in mind. So what is the prevalence of depressive symptoms? Are they higher amongst stop daily smokers? And if you take a look at the depression severity among stop daily smokers, this is about only a sample of 32,000 smokers from Ontario, from many of you who have contributed these data, and these are the people you have treated for their smoking. From Jan 2014 to April 2016, you'll see that minimal depressive system is 2.5%, 5% have major depressive, mild, 4.3 are moderate, and 2.8 are major. And overall, which is really interesting, is that only 4% in comparison of Canadians will experience major depressive in any given year. And so what we are seeing is as you're beginning to take care of people who are quitting smoking, you're oversampling people who have depressive illness or active depressive symptoms. Now, we know that there are lower quit success with increasing depressive symptoms. So if you look at the 12-month quit rates amongst the daily smokers in the STOP program without versus those with depressive symptoms, you can see that those who have no depressive symptoms at all, their quit rate is closer to about 32%. And if you go down with minimal, it drops down to 29 and stays with the minimal and minimal depressive or the mild severity. But as soon as you get moderate to major, you can see statistically significant drops. And so you can see that difference between no symptoms at 32% and major depressive severe at 23%. So there's roughly a 9% difference between these two groups. So important point to note, because we need to help that group that's coming to us to quit smoking to optimize their chances. And imagine if you're depressed and you appear to internalize quitting smoking or failing to quit smoking as a failure. Here's yet one more thing that you haven't done well. So we need to help people who have mood disorders increase their options for quitting successfully while they're doing that, because we know that when people quit smoking with a mood disorder, it's like the effect on their mood is like adding another antidepressant. So getting rid of the smoke and then it really helps improve mood in the long run. But they have to overcome that acute withdrawal and be helped so that they can become tobacco free. So there's plenty of evidence for mood interventions to achieve cessation, and there are Cochrane reviews, which are, for those of you who are not familiar with Cochrane, it's the world-renowned place where many randomized trials are then taken and put into meta-analysis or systematic reviews where we look at the collective evidence that exists for any interventions that we are doing. And Tobacco Addiction Group has been working for 10 years and more, and you can see that there are many reviews from many different groups about adding mood management interventions to smoking cessation programming significantly will increase the likelihood of quitting. And I'm not sure what happened here, but we'll see. There it goes. So increased by 47%, increased chance of successful smoking cessation if you add the psychosocial mood management intervention compared to standard care in smokers with a current or past history of depression. So if they are currently depressed, you increase the chance by 47%. If they're past depressed, it increases by 41%. So do you currently provide mood interventions? Again, 35% of practitioners report over half of their patients will demonstrate depressive symptoms. And this comes from our Teach Webinar and Stop program survey with family health teams that shows that, and 45% of practitioners report providing counseling to their patients with depressive symptoms. So at least half are doing something, approximately half are doing something about it. But when we talk about confidence about it, most people are somewhat confident, only 6% are very confident, and we have about 34% who are either not very confident or not confident at all. And that's one of the reasons why you're here, and that's one of the reasons why we continue to do the work through Teach and Stop, is to make sure that whatever you can do to help your job be done better, we are there to actually pay attention to what the patients are doing, triangulate with what you are doing already, and then try to help improve how we help people who use tobacco and have other comorbidities live better lives. So what does an evidence-based intervention look like for depression? And again, the intervention depends on the level of depression severity and symptoms. And the foundation of all treatment levels is to do a brief intervention and provide educational resources, because where you're seeing people, now this is not an intervention that I would say that a psychiatric hospital should do, but this is where primary care or frontline care, where we get a range of patients, this is where we start. This is not necessarily where you may end up with everybody, but this is where you start, because most people who come within primary care symptoms will be the mild to moderate, and you'll have fewer with the severe. So we need to pay attention to this. So if people are beginning to show minimal depressive symptoms, which is based on the PHQ score 5 to 9, they could respond quite nicely to educational resources, a workbook, and a small brief intervention at best. If they get to mild severity, then clearly they may need psychotherapy if appropriate, or referral if appropriate, depending on what the resources are available. And as you have heard, the Ministry of Health is deploying a lot more psychotherapy availability across the province, so that should become a much more accessible resource in time. And then clearly if it's major depression, moderate severity, this is where you're getting the physicians much more involved. And again, most likely these people are going to need combination therapies of psychotherapy and pharmacotherapy, maybe more than one pharmacotherapy if they're not responding. And then, of course, for major depression severe, they may need immediate referral and pay particular attention to suicide risk. So if somebody is severely depressed coming in, addressing their tobacco addiction is important, but making sure that they live and that they're well enough to participate is also important. So your focus in this, in this population, maybe making sure that their depression, especially their suicide risk, is paid attention to on an ongoing basis and immediately. So so that's how you could layer it. And then addressing suicide risk in practice, because people don't come into primary care settings saying, some will do, but that's easier, but sometimes it's below the surface. So what am I listening for from my clients? And here are some of the issues. So clearly, when they're coming to quit smoking, in the PHQ-9, if you've done that, have they answered that suicidal ideation question, that last question? When they show up, are they intoxicated? Are they in withdrawal? Are they using multiple substances? Is there personal or family history of suicidal attempts? And are they currently undergoing some life stressors, serious medical diagnosis, new diagnosis given to them, lost a job, lost their income, things like that, lost a spouse, divorce, etc. Those are kinds of things that one needs to pay attention to when you're looking at assessing suicide risk in clinical practice. And this is not just for people who are coming in to quit smoking. It's in anybody, actually. Anybody who comes into our setting often could be experiencing these things, and one has to bring up that conversation. So how do you respond? Obviously, people on this call are working in different organizations, and you need to follow your organization's policy on what risk assessments and follow-up actions you do. And if you don't have a policy on risk assessments and follow-up actions, strongly recommend as a quality indicator. That is an important quality improvement that is required in any organization, whether it's a hospital, primary care setting. How are we responding to people with higher and lower risk? And clearly what often has to happen with this is we have to have a safety plan with our client. And again, what they do if they feel an urge to harm themselves, and what are the coping skills, what's the call-up, what's the follow-up, what's the emergency plan. So having clearly articulated that they understand it, and at times making that decision that this is way above your experience, and you need to get them to be seen by a physician right away, because any physician has the ability to essentially create a Form 1 or certify the patient and get them sent to an emergency room for a psychiatric evaluation if they need to be admitted, or etc. And so, as a third thing, which I mentioned, is that clearly in creating that crisis plan, a list of emergency contacts, the crisis line, closest ED, friends, family, and of course the follow-up with you. So what we've looked at the STOP portal, and we've really looked at that. What are the PHQ-9s coming in from people who are quitting smoking? And you've seen the data, and we felt that as to improve the chances of a particular patient population, so that we don't have a disparity develop, that if you have fewer diagnoses, you're going to do better with our treatment. We want all boats to rise, and we want all people to do as well. So what we want to do is we've got some money from CHR, and what we want to do is the application of the existing mood-related screening tools and STOP baseline questionnaire. Are those actionable items there that we can do something? And can we help practitioners with in the portal as you're assessing? Many of you are now doing your assessment with the patient in front of you. That while you're assessing, can it give you some decision support while you're doing that? So should the PHQ-9 give us some indication, you actually have the tools at your immediate disposal to hand over to the patient to improve their chances of having a successful cessation. And if there's a risk, you're able to detect it and have a pathway that is within your organization to get them the care. So the intervention guidance and educational resources will be available in the online portal for all our organizations participating in STOP. So let's take a look at what that looks like. As you know, when people come to quit smoking, in the portal, you do a baseline questionnaire. And as part of this is we've paid attention to practitioners. You have a lot of control over this. This is not it guides you, and you can figure out a pathway through this, and it allows you to enter it if the patient is with you at the moment. So what are the 3 steps to a mood-based intervention? Is first of all, obviously screening, and that has been happening. The part that we're going to talk about today is the brief intervention and referral to treatment that is going to be necessary if somebody does have a mood disorder. So what are the things that we can do? So we will continue to measure the history of depression and associated medication. So that's not going to change, and we've been paying attention to this, and this helps us know what are all those risk factors that our smokers are experiencing. And as you know, we talk about these other cardiovascular risk factors like blood pressure and cholesterol, but we're also interested in the other things like their mood and levels of anxiety. So, and if they're taking medications for that, because that helps us know whether people's treatment actually is working or not working. And one of the worst things that we have seen in our in most healthcare settings is that people may think they're getting treatment for their depression and anxiety, but nobody's actually measuring if they're actually responding to the treatment. And many people are undertreated for their depression and anxiety because people may have started an antidepressant, but they don't actually optimize the treatment. So what will happen is the full question will automatically be scored in the portal so that the practitioner doesn't have to worry about adding up and wondering where it is. And as we know, the options will be 0, 1, 2, or 3, and it'll use the total score to guide appropriate intervention. And as you know, we talked about question 9, that screens for suicidal ideation. So you will see if this is thoughts that you'd be better off dead or hurting yourself in some way, that will certainly create an alert that. So let's move on to the next slide. And what I want to do is to bring it to life, and we're going to use 2 case studies to illustrate the point. So one is Paula, and the other is Nav. And Paula is a 68-year-old female, married, retired, smokes 25 to 30 cigarettes a day. And notice, usually when you have the heavily dependent smokers, they're much more likely to have a mood disorder. Psychiatrists are most likely to be a mood disorder. They report 9 quit attempts in the past year, so you can see that they're really, people with, the rates of trying to quit are not necessarily different between people with mental illness and those without. It's just that they don't tend to be as successful because we haven't really adapted our treatments to help them. Now, she talks that during her quit attempt, she has little interest in hobbies, has trouble sleeping, gets poor appetite, and has not consumed alcohol in the past 12 months. On the other hand, Nav is a 41-year-old male, smoking 2 packs a day. Longest quit attempt has been less than 24 hours. And during the quit attempt, reports feeling sad, nervous, fatigued, inability to focus, suicidal thoughts, engages in binge drinking several times a week. So we've got these 2 sort of case types that may be showing up there. We'll take it, we'll examine these two patients. So let's work with Paula first. She's got a history of a depression question. Have you ever been diagnosed with the following? So this is lifetime, and she says no. So there's no diagnosis of depression, and it is, they may have been depressed, but they just never been diagnosed with it. And sometimes people can say, I don't know and prefer not to answer. So that's there. That's one question that you can, that's our single question screener. But then we feel that sometimes people may not have been diagnosed, but they may currently be experiencing symptoms. And so the 2 questions of the PHQ-9, this is the ultra-brief screen, over the last 2 weeks, and this is telling us where somebody is currently. How often have you been bothered by any of the problems? Little interest and feeling down or depressed and hopeless. And she says more than half the days and several days. And so when you screen positive on this, it will automatically prompt the full questionnaire for the person and automatically ask the remaining 7 questions. And again, if you notice, she reports that, but no report of suicidal ideation. So now you've got somebody who's screening positive for a depressive illness, and so what does that brief intervention look like? So how will the STOP portal help you? It'll say, attention, this patient is reporting minimal depressive symptoms. If you like, you can go back and review the patient's survey responses, but the portal will score the responses to mood screening tools and provide an interpretation for you. And it'll offer you the option to provide scripted or unscripted brief interventions. As we know, across all the STOP sites, some people are way more comfortable with mood disorders and providing that and already developed a plan. So this is not intended to replace that. And for others, they are on that learning journey and have never done or have just learning to do this. And so you have a choice here of providing your own intervention, or you will not conduct the intervention, or show me how to do it. Right at that moment, it can guide you. And so what does it look like? Just remember M and M and M. So I wish I had M&Ms to show you, but the 3 M's is what we're saying is. Critically, if somebody shows up with a mild moderate mood disorder, make the connection. Say, I noticed that on this questionnaire about your mood, you demonstrated, you said the following things. Don't say you scored badly, because sometimes that freaks them out. Say, this is what it looks like. You've got some minimal depression symptoms, and we know that there is a link between these mood states and smoking. Validate their feelings experienced during cessation. So I understand that it is hard. This is not just something you're making up. This is naturally happening to you, and we can see it. Validation of a client's feelings is extremely important to get them engaged, as you know. Then ask the readiness to change. So we measure readiness, make the connection, measure readiness, and again, really make sure that, affirm that they're coming to quit smoking despite having depressive symptoms, that you're there to support them through this process. And then clearly make a plan as to what are some of the collaborative goals for future visits and how they're going to manage their mood state as they're going through. So that's what really a brief intervention looks like for mild, minimal symptoms that she has. So in Paula's case, you make that link. Okay, you have little interest in doing things, feeling sad during a quit attempt, you get fatigued and smoking. So what are some of the things that we can do or you can do when you're quitting, if you're using NRT, what else things can do to help your mood? Because it's not always medication that is needed. It could be support. It could be talking to somebody. It could be massage. It could be these other things that help. It could be mindfulness, etc. Measure her readiness and then make a plan. So the third step is referral to treatment, whether it's an educational resource and or referral, for care. And what the portal also does is do you want to provide this patient with take-home resources on mood management? You can say yes or no, thank you, or patient declined. You have some options. And the portal can give you options to provide any of these resources for mood, alcohol, nutrition, physical activity, sleep, or stress. And you could provide them, all of them or none of them. That's your choice, and they may accept some or none. So that portal helps you decide what you want to give them. And here are some of the resources that have been being developed, and this comes from the randomized control trials and from Munoz, who's in California, who developed this. And look at the date in when we knew depression affected cessation. 1995. 22 years ago. And we are just about getting to it in 2017. So, and I take responsibility from our perspective that yes, we could have done a better job earlier, but clearly this is something that, taking evidence into practice 20 years later. So, but it's never too late because our patients are showing up with these symptoms and there is evidence that we can do something that will help them. It's very simple. The mood education resource is a tracking sheet and tracking participation in positive activities, obviously cigarette smokes and the mood, and it'll soon be available in the STOP portal for use. What are the educational resources that she can get? So one is obviously goal setting and engaging in new healthy activities and cutting down cigarettes or stopping cigarettes before the next visit. And again, it'll be offered based on the severity of the depression score. Now, how do you share those resources with the patients? You can email, print, or have it already pre-printed, and they will be there on the STOP portal. And you could, as I said, send it by email to them if they have email, or print. So making it as easy as possible for you to provide that intervention. So that's for the mild, minimal symptoms. Here's the simplest intervention, shouldn't take more than a few minutes, and helps you make sure that somebody like that is optimized in their quit attempt. Coming back to Nav, who's a much more heavily dependent smoker and has more symptom severity of depression, he does report a history of depression diagnosis. And he has been positive on the brief questionnaire for the PHQ-9. He does have, in several days, he has had little interest or pleasure, and he's been, every day feels down, depressed, or hopeless. So That is a concern, and then several days that he's had thoughts that he'd be better off dead or hurting himself in some way. So now, I mean, these are rare events, but you may have it, and so you need to know what to do with it. And it's, first thing is do not panic. Take your pulse and calm down. By asking about people there's a common myth that by asking people about suicide, that somehow, oh my God, I've put the idea into their head and now they're going to want to go and do that. That is a myth. That is part of the stigma, and that is part of why we actually may be making it worse. What is left unsaid is way worse. And so asking at-risk populations about it in a matter-of-fact way does not increase subsequent increases in ideation. If anything, it'll get them connected to healthcare. So in this, you'll get this portal will say now he's responded to this both for alcohol and mood, and it'll recommend an intervention for mood and alcohol, and it'll offer you the option to provide scripted or unscripted interventions for both. Because when the good thing is when we've looked at that question 9 and all from 2014 to 2017 of clients in the STOP program who report that question, it's about 4%. So it's not minimal, it's there. We haven't just been doing anything about it. So I think it's time that for everybody's well-being, we need to pay attention to this small group. Most often you're not going to, but this is what we would do if somebody shows up with this. And why is it important? Why are we paying attention to this? Because as you know, as the prevalence of smoking is dropping in Canada and Ontario, the remaining smokers are much more likely to have a mental health disorder, and depression is one of the most common. So ignoring it reduces the success rate of smoking cessation. So what can you do? Immediate support in response to somebody of this thing says it, you can conduct an immediate risk assessment. So obviously follow your organization policy on risk assessment and follow up actions, whether it's calling 911, depending on where you practice, immediate referral to the specialist, consultation with your nurse practitioner or the physician or somebody else or your boss, whoever it might be, depending on your setting, follow that. While you're doing that, help that person develop a plan in the event of suicidal thoughts returning. Are they currently present? Is the person currently having an intent to continue? Is they say, yeah, after I leave this, I plan to go kill myself, and I have the means. That person should not be leaving your office. That's a rare event, but it does happen, and this has happened to me when I was in family practice as well, and you just have to respond to it and in a kind, calm way, and get the person to the right care, to the emergency room. But if the person says, no, I have these passive ideations, I'm never going to do it, I've got protection, I've got a good family, it goes against my religion, I didn't even know if I were going to do it, I wouldn't even know how to do it, then you can help at least the person develop a plan of how to help them when they're having suicidal thoughts. How do they distract themselves? How do they call a friend? How do they get help? How do they reach out, etc., etc.? How do they get the emergency room? Where do they go to? There's a distress line, etc. If your clinic has an after-hours distress line or a line to call the physician on call or the nurse practitioner on call, then make sure that they have it. And what are the other supports and treatments that the person needs? And then what are some of the coping mechanisms in general, such as managing stress, etc., and stopping and reducing alcohol. Stopping alcohol completely actually is recommended in patients who have these kinds of feelings, because they really need to pay attention to that. So the first thing is immediate safety and risk. So if your gut is telling you this is risky, consult with somebody more superior, get them assessed and get them sent out. But if, on the other hand, they're not, explain to them why you had to do what you had to do because you're concerned, and most people actually thank and welcome that. Actually, if you get angry with them or you get anxious about it, it makes them feel worse. So it's really important to be calm and follow the steps of making sure you assess the level of risk and you have a plan. So if appropriate, say he says, no, these are passive ideations, I'm not really going to do this, I'm not worried, I have a good safety plan, I've never made an attempt before, let's continue, I've really come to quit smoking. And that is an interesting thing. If people are coming to quit smoking, they're thinking about future health because, that's often why they're there. So really talk about how his mood-related information, his information that he filled in, his inability to focus, feeling sad during quit attempts, drinking and smoking, are all connected, and that what can be done to manage that acute withdrawal state so that when he is going through that quit attempt, he doesn't experience that low, and what can he do to manage that, including pharmacotherapy and some behavioral interventions that we talked about. Again, measure his readiness, and in this case, you're often going to get high importance, low confidence, and again, help him work on that confidence. Now, it's very difficult when people are depressed for them to see any positivity, and so it's sometimes very helpful. You need to be gentle. You need do not be dismissive, and do not be Pollyanna with them. You really need to help them say, okay, I know how hard it is. So more affirming language. I know how hard it is to quit smoking, especially when you're dealing with these mood states. Thank you for trying. I'm here to help you. That kind of language helps people, even when they're most depressed, not to feel that somebody's telling them, oh, just cheer up, buckle up, etc. But you're actually acknowledging how much harder that is for them to do it. And rather than be demotivating, it actually motivates them to try harder. And ask them if they're ready to make a plan. Getting more physically active is both good for quitting smoking, but also good for mood. So working through that with them is important. Now, what about referral? You could give them a take-home resource, an alcohol resource, because he's screen positive, and then these additional resources are also available. Should the decision, you made the decision, no, he doesn't need to be seen by the physician or the nurse practitioner. He's okay. He's okay to move forward, and he wants to move forward as an outpatient. Here are some of the ways in which you can give him specific resources for him to work on. Again, this is the mood resources. Plus, if he is showing anywhere from moderate, mild major depression to the severe major depression, please follow your organization's policies in terms of referral to psychotherapy, medications, or both. And that would be like any patient who you saw in the clinic and described it. What you're doing now is just being more deliberate about it and demonstrating that you're looking for it and actually helping people. So now what we're going to do is go to a poll question, and I'm not sure if I can pull this. Oh, it's going to be pulled in for me. Wow, that's fantastic. Okay, there you go. Take the poll, and we're trying to gauge how many people who are within STOP and use the online portal have interest in using it, who participate in STOP, don't use the portal, and would like to see the portal being used. Okay, so we have about, we'll keep it open for a little bit longer, just so that people have had a chance to vote. And okay, so we have about 10% who don't use the participate in STOP, don't use the portal, and it could be because you're doing Stop on the Road, or you're doing something where we don't use the portal in general. We're certainly helping that develop better so that it can better meet the needs of these the complexity that patients who smoke have. And so we know that there are at least 63% who participate and use the portal, and we have about 25% who want to look at using the portal if possible. And so feel free to email us and tell us your ideas. We're going to take a list and look at how we can actually be more adaptive and inclusive with the use of the portal. So stay tuned. Okay. So in the winter of 2017, so actually more likely 2018, the Mood Management Initiative will be launched. So in addition to this better screening and actually helping you have a score and give you some ideas as to what you can do, that is going to be there. There will be the STOP teleconference to address questions, the troubleshoot questions with the portal, and everybody will get lots of advance notice when the portal is being updated. But clearly, we think that this is going to be a quality improvement to how we help people who quit smoking and help you manage that in a more systematic way across all the sites, so that people, whether they're coming in Northern Ontario and Kenora, or whether they're seeing in Toronto, they're not having differential experiences of trying to quit smoking. And the last I want to put up for you is we actually understand that within our primary care settings and other settings that there are lots of patients who have, elderly patients who are flying under the radar. And when we look at our stop data, we have a fair number of people who over the age of 60. At last count, we looked at it, we have 3,000 patients over the age of 60 who have a PHQ score of 6 or higher. We estimate that at least 8% of those might have treatment-resistant depression. So if you take it as 10%, there's 300 patients in Ontario right now within our stop intervention who are suffering, elderly patients who are suffering from depression. So one of the possibilities is for those patients, if you identify them, if we identify them, is speak to their physician, because we have a way to help those physicians better manage that patient's depression through guidance. And the patient doesn't have to come to CAMH or come to Toronto or anything like that. It's all done remotely. They get called by a mental health technician and get assessed, and then we review that assessment and provide consultation to the physician to help improve the care of that elderly person with depression. So this is on the much more what we would call treatment-resistant depression. And so you can start seeing in our smoker population, people with depression are overrepresented, and we want to make sure that if we are creating something, we are creating from that entire spectrum that you see in primary care, from no symptoms to mild symptoms to moderate symptoms to severe symptoms. And what we've built here with the OPTIMUM one is for the more elderly who are often forgotten in this. So, and we have at least 3,000 of them out there who potentially have those first two criteria, and we predict at least about 10%, 8 to 10% of that have treatment-resistant depression. So if you have patients like that, when you're assessing them, you see, in addition to stop, this person really needs to, has really significant depression, speak to their physician and let them know about the OPTIMUM contact, and that the patient can call directly, the physician can call, and the patient can get enrolled and get access to care. AFTO, which is the Association of Family Health Teams of Ontario, is running queries for any family health team that wants to find their treatment-resistant depression patients. Get in touch with AFTO and they'll run that for you. And you can have a systematic approach to the management of depression in your practice. So I want to summarize that today's talk, we talked about how do we systematically look at mood in patients who are quitting smoking. Some of you may or may not be aware that Dr. Charles Ellis, myself, and Diane, who we've just published our second edition of Disease Interrupted. Actually, in case you haven't seen it, we will be doing a webinar sometime soon about it. But it's out there. The new edition is out there. And in that, we've talked about the safety-sensitive screening in tobacco intervention and screening, and mood disorders are a really important part of that. We've shown you data about how by not paying attention to people's mood disorders, their quit rates suffer, and that we do have depressed patients. We do have a evidence-based intervention for that spectrum of conditions that come across primary care settings and community care settings, that you have a pathway to follow to help your patients. And even if you're not prescribing the medications, you know who you should be sending to see the physician, or at least talk to the physician member of your team or the nurse practitioner team about this. And we are trying to help through the STOP portal to help that improve just so slightly. And it wouldn't be possible without all your participations. And we look forward to hearing from you as this rolls out, how it's going, and what we can do to help make it better. So open it up for questions. We have 10 minutes, and I'm starting to look at the chat that have come in, and I'm going to just slide down. I'm going to start from, okay. The question is, the baseline questionnaire available? The baseline questionnaire is available for STOP. There's a print version of that. And information about optimizing treatment for depression, you can see, obviously, once people are getting into the moderate to severe depression, what you're doing is you're going to start off with clearly eliminating things that could be causing the depression, such as alcohol, drugs, etc., medications. Make sure that there's no sort of other physical diagnosis, untreated pain, etc., that's making the person depressed. They meet the criteria for depression. They start on some of the safer antidepressants for 6 weeks. If they don't get a response, then there may be an issue of either adding another antidepressant or augmenting the antidepressant if you make sure medication adherence has been fine. If that's not the case, then and then you've got total of 12 weeks of antidepressant treatment, and their PHQ-9s are not down to the no symptoms. Even if they're having minimal symptoms, you need to keep pushing until they get into full remission. Often what happens with depression is we partially treat the depression. People are feeling so down, they're taking antidepressants, they start feeling a bit better, and it just puts them over that edge, but they're still struggling. They aren't in full remission, and when you do that PHQ-9 again, you see that they're still struggling. That actually should prompt for further interventions, whether it's psychotherapy or with the CBT, because psychotherapy plus antidepressants works better than either on alone. And for mild to moderate, in fact, psychotherapy may be your first line. But treatment remission, full remission is necessary. Clearly, that's roughly treatment optimization. And then, of course, as it gets much more severe, not responding, definitely getting consultations from psychiatry is critical, because clearly they may need more sort of augmentation treatments. They may need other things that is required. And clearly for young people who are depressed, pay close attention to it, because of the immature brain. They're often impulsive, and so you do need to make sure they get seen by whether there's a youth collaborative, mental health collaborative in your area. Find out what that is. Make sure they get connected as soon as possible into a mental health setting so that they can get that treated as well. Okay, so I hope that answered your question, Mark. And the PHQ is available in electronic form in the STOP portal. And that's it. About the stages of change in reference to measure readiness. We tend not to use the stages of change as much, because they tend not to be enduring states or enduring stages. And if you're using motivational interviewing with your patients, you may have somebody who's come in the so-called pre-contemplative state, but if you're effective with them, you may have made them ready or prepped to take action. So if it's a useful heuristic in your own mind to work where somebody's at, it's important not to label the patient, because sometimes it gets them sort of stuck, and it stops you from motivating that change. And so we've kind of referenced the stages of change, but we really are looking at, in the moment, how important is it for this person to quit, and how confident are they're going to be able to do it, so therefore how ready are they, and what can we do to enhance confidence or enhance importance with them. Yeah, so I think, Bridget, you made a really good point. I've had patients say they're not comfortable with the questions where the choices are not at all, or several days. They have commented maybe once in a while they feel that way, but not several days, but they feel they can't check off not at all either. Any suggestions to this is, I think, this has been a part of any validated questionnaire, that we don't have a 0.5 mark in there. And clinically, what I would ask people to do is, like, if they've marked it not at all, just say, okay, you've told that to me, that's great, and that's okay, and thank you for being honest with me. Or if they marked it 1 and they said, well, it's not really a 1, it's a not at all, you can say, okay, thank you for being honest with me again, and thank you for letting me know where you're at. So remember, these are screening questionnaires. They are not about 100% precision, because I can tell you, as soon as you start going for 100% precision, you'll end up with a lot of noise. We are seeing this actually in high blood pressure measurement. The more high blood pressure measurement becomes automated, the more noise that there's beginning to occur in actually what the cutoff is, whether it's the right cutoff or not cutoff. And the real risk we face with hypertension blood pressure measurement is that it's creating such confusion, people may just back off doing what they're doing and not actually measure the blood pressure, which would be an unintended consequence. So any instrument, whether it's a questionnaire, whether it's a blood pressure measurement, or you have to apply clinical interpretation to it. Remember, machines are not going to take over our world because we still need to think these things through. So that's how I would approach it, Bridget, and I hope that makes sense of how one can do that in that case. So yeah, and zero suicide is generally most institutions. So Leslie, thanks for sharing that, and all of us, and thanks for sharing that link. I think that's an important one. We should essentially work towards zero suicide method, because if we don't try, we will never get there. So let's try to do that. And it's important. I think Vitaly and others have all said that they are having this same issue about the PHQ-9, and we must make sure that we acknowledge when addressing the mood. We must understand that the questions are not perfect, but when we ask that with the patient, they can say that. Yeah, and I think the how soon, stay tuned. We don't have it takes a little bit of programming and validation, so we will be communicating that as soon as possible, as soon as we know. As always, the presentation is accessible through archives, and it will be available. It's recorded, as you know, so you feel free to use it, share it, tell other people to watch it, and yeah, and of course, resources available to anybody, even if you're not on the wait list to get into the STOP program. We are thinking of ways in making a lot of, the wait list issue is really the NRT piece, but there are so many other resources that we have, and we are really wanting to work with any healthcare provider to see if they want to access those resources, even if we don't have the NRT to give them, but they can use some of those questionnaires, the ways of thinking about it with their patients. So please be in touch with us. Okay. Okay, and Catherine asked, is there any correlation to mental health issues and young adults who start using e-cigarette? A very interesting thing. We know that the earlier somebody starts experimenting with any substance, tobacco, alcohol, whether it's through e-cigarettes or cigarette, they sample. If they sample one, the probability of sampling other substances goes up exponentially. And if you look at the OSTER survey, which is the Ontario Students' Health Use Survey, I think it's less than 2 or 3% of students in grades like high school actually only use cigarettes, only use tobacco. The bulk of them that are using tobacco, marijuana, alcohol. It's this trifecta. So electronic cigarettes often will suggest that people who try electronic cigarettes will then go on to use cigarettes. But there are these other issues that we know that if some kid starts smoking, that is a red flag that this kid is, over time, I shouldn't say kid, but this young person, over time, is either going to develop a mental illness or other substance problem. It is an indicator of risk. The earlier somebody starts smoking in 2017, we need to watch those kids, because that's an indication this kid is going to go down a path that is not a healthy one. So, and whether it's e-cigarettes or cigarettes, it's what's available. So that is important. And again, directing people to CAN-MATH guideline, that certainly will be part of it. Thank you for putting it up there. We will look at how that becomes part of that resource, and that's why that resource checklist is being validated. We are trying to figure out what are useful things to go, and we are checking with some of our experts in mood disorders at CAMH, Dr. Arun Ravindran, for example, about what might be useful resources to put in there. So, and as Leslie said, the PHQ-9 starts the conversation, and this is exactly where it is. We've done some focus groups with people in STOP, and which is the practitioners, and they're I don't know, Leslie, whether you are the person in the focus group, but many practitioners are saying to us that, guess what, I never had a way of bringing up this in a useful way with a client, and I wanted to talk about it, but I could never. And by participating in this, it's allowing us to talk about alcohol and depression like we've never done it before. And it is making our practice much fuller. We're practicing better to scope, and I think that's an extremely important change, unintended consequences that we've noticed here, that within STOP that practitioners are doing and are beginning to practice much more whole person medicine than just giving them smoking cessation treatment. So if someone says once in a while, we would mark them at not at all, and I think that may be better to market that. And I think when you clarify with them, you use your clinical judgment, of course, to see is this person sort of, minimizing or appears to be minimizing versus not. And again, you can always keep it in mind and say, okay, since the last time we met, I know you mentioned it was once in a while. How are you doing? How's your mood? And if they say, no, that's all, in fact, I've quit smoking and I'm much better, my mood is much better, you know that quitting smoking is helping. Okay. So the last, we had 1 o'clock, and so Catherine, we will take your question to access the portal information. We are working on a portal for patients. We're hoping that'll be ready as well, and in that case, they will have access to all this information, even if they're not ready, so they can sort of they can just take a test drive and see is this what they want to do. So we will take that into consideration, and thank you very much for everybody's participation and comments. We are always open to your feedback and evaluation. So have a great rest of day, and I want to thank everybody who's taken the time to be here with us, and I want to thank my fantastic team and Saliza, who's going to say thank you and bye now.
All right. Thank you, Peter. I think that was really informative. So before you go, just again a few housekeeping items. So remember, a link to the evaluation and post-learning assessment will be sent to you by email either this afternoon or tomorrow, and you'll have 1 week to complete the post-learning assessment in order to receive your letter of completion. If you did participate as a group, please make sure to email teach@camh.ca with a complete list of participants by 2 p.m. today. And our next Teach Educational rounds will be held on November 15th, and it's going to focus on a complex client case with addressing tobacco use with youth. So what we want to do is invite you to submit a complex youth client case that you may be struggling with in your own practice and perhaps want to discuss during the webinar. So registration and a form with your complex case will be opening next week, so stay tuned for that.
And youth aged up to age 29.
Okay. Okay, yes, youth included up to age 29. And again, if you missed the beginning of this presentation, you want to view it again, or you're interested in seeing previous Teach webinars, you can access those through our archive page on our website. And finally, thank you all for joining us, and have a great rest of the week.
Yeah, and happy Diwali for those of you who celebrate Diwali this week.
Bye.